Can everybody hear us? Yeah. Excellent. I think we're going to start now. Thank you everyone for coming to this evening's mental health question time. My name is Parita Patale. I'm going to chair this event, and I'm going to first introduce all the speakers. Then they're going to do a 3-minute pitch about the key topic of today's discussion. And then we open it up to questions. I will start with a round of questions to each speaker, and then we open up to everyone for questions. So please think of really nice questions to ask our panel. And yeah, we'll get started. So I'm going to make introductions from that end of the table to this end of the table, and then for the 3-minute pitch, I'm going to sort of ask each speaker when their turn. So just to make quick introductions, our first panelist on the far end is Professor Sir Michael Marmot. You probably heard his keynote today, so I'm not going to do the long introduction. So he's Professor of Epidemiology at University College London and Director of the UCL Institute of Health. Our second speaker, or the second panelist from that end, is Jen Dykehorn, is a psychiatric epidemiologist and public mental health expert and a senior research fellow at UCL and now an NIHR advanced fellow. Our third speaker is Shiranjit Singh, is a mental health advocate, lived experience consultant, and current doctoral student at Oxford University. He also founded the amazing Taraki charity a few years ago. Our fourth speaker is Sarah Joy. Sarah has worked within mental health and the community for over 7 years, with a focus on health inequalities and holistic healing practices. Our fifth panelist is Dr. Jayati Dashmunchi, is a clinical reader in social and psychiatric epidemiology at King's College London Centre for Society and Mental Health, and also an honorary consultant psychiatrist at the South London and Maudsley Trust. And our last panelist is Kadra Abdinasir, is Associate Director for Children and Young People at the Centre for Mental Health. So welcome everyone, looking forward to this next hour and a half of chat. Michael's going to leave at 6 o'clock, which is why he's sitting at that end. He's just going to slip out at 6 o'clock, but then everybody else is staying for the full session. So, our starter question that everybody got to already prepare for is, what factors should governments, policymakers and public health practitioners prioritize to reduce inequalities in the risk of, treatment for, or outcomes following mental health problems? And for this sort of starter pitch, our first speaker is going to be Shiranjit.
Awesome. Can everyone hear me? All good? Lovely. So as mentioned, my name is Shiranjit Singh. I'm a lived experience consultant, mental health advocate and a current PhD student as well. I'm a proud resident of Handsworth in Birmingham, a place full of amazing migration, cultural creation and community. And when I was thinking about my response to this question, I was going to give a bit of a boilerplate response about housing and statistics and stuff, but actually what I decided to do was to give you a window into the life of what I see every day in Handsworth. So I wake up to the sounds of birds singing, rustling trees. I do a bit of my morning routine. I look outside. There's a man sat on a bench with his hands on his head. He's there once or twice a week. I don't know where he sleeps. I don't know where he stays. I walk to the local Gurdwara, which is a Sikh place of worship, a socio-spiritual centre, one of many for faith-based communities in the local area. Many go to their places of worship for that type of sanctuary. As I'm walking, I look to the side and there's a large pile of rubbish, which is being cleaned by a resident. Someone had dumped it there. There's a sofa, needles, a condom, and stained clothing. I give an appreciative nod to my fellow resident who's cleaning that up, because I know that school children are imminently about to come into the vicinity. I'm in the Gurdwara. Here, over 1,000 people and volunteers are supported each week through prayer, preparing and delivering meals, and importantly, keeping each other company. I think back to what it was like during the pandemic when the doors had to shut for the first time since 1977. After I finish at the Gurdwara, I'm walking back out and I notice the pharmacy that's opposite, and there's someone who's heavily intoxicated. Heavily intoxicated, living in a supported accommodation close by, trying to pick a fight with someone at the bus stop. There's community-funded security team who are there trying to de-escalate the situation. Families are walking past, some are worried, some don't notice, some are completely desensitized. I check in at the health centre where I run an adult counselling service. Our referrals are up. Waiting lists for other services, employment challenges, housing challenges, finance, bills. Our free service is a plaster, but it's not enough to save a house that is crumbling at its foundations. I go home and I start my own work, which I'm not going to talk about today because it's awfully boring. And I have an email from a researcher asking to connect with our community. What does that even mean? I look outside and there's a tenant speaking to their support worker, complaining about rats. I go outside and offer my support to escalate the challenge with Birmingham City Council and their environmental team. I'm on my evening walk. Our communities are laughing, joking, and surviving through a spirit of strength and self-reliance. I go to a small community allotment that we'd created with a local school to harvest some corn, basil, and radish. I've got no idea what I can do with those things together. I recognise that our communities are holding the neighbourhood on their backs and have been for the last 50 years, but we can't rely on them forever. On my way back, I see street sex workers and vulnerable tenants, needles, condoms, and stained clothes. When I was asked to speak today and reduce my talk to one issue, I found it absolutely impossible. We know the world is complex and multi-layered. And like one of those English essays I was really bad at when I was younger, we all notice something different in the scene and the reality that I've described to you today. Real people in that reality. Children, families, healthcare workers, residents, businesses, sex workers, vulnerable people. When I wake up tomorrow, it will be the same. It shouldn't be, but it will be. But, as the speaker before me said, I remain optimistic and I remain hopeful. So I ask us, what are we going to do about it? Thank you.
So our next speaker to answer the question of what factors should governments, policymakers and public health practitioners prioritise to reduce inequalities in the risk, treatment and outcomes following mental health problems. Also factors, so it can be more than one thing. And Jen.
Great, thank you so much, and it's really a pleasure to be here on the panel. This is a really difficult question. I spent a lot of time thinking about how would I reduce what needs to happen to reduce inequalities. How could I boil that down to 3 things? And I'm not sure how good of a job I've done, but I'll just start. But I want to take us to a bigger picture to start with, because fundamentally, if we want to reduce mental health inequalities, it's imperative that we focus on the wider drivers of inequalities. So access to secure housing, adequate income, ensuring human rights, these really basic tenets of what every person needs are absolutely essential before we can even begin to start to move the needle on mental health, preventing mental health problems, supporting people through treatment, and getting positive outcomes for those who do have mental health problems. Practically, what does this look like? Practically, governments, policymakers, practitioners really do need to embed this idea of mental health in all policies, in all of their policies. We need to think about mental health. We need to think about the impact on inequalities when we're thinking about how we design our cities, when we're thinking about where we're going to be building facilities and where we're investing money. The next thing that I wanted to really talk about was when we think about the main drivers of mental health problems, it does come down to systemic issues. And what's been already mentioned today, and some of the other speakers throughout the afternoon have talked about how systemic these issues are and how structural they are. And a very famous quote that I can't find who it should be originally attributed to is, "The system isn't broken, it was built this way." The machine is running as it's intended, which is something that Ta-Nehisi Coates said, The system is currently built to reinforce the existing power structures, and we do need to dismantle the way that the system is built. So this means that we do need to take a structural perspective, and that's not hard. It's very hard to measure the structures. We know that all of these systemic issues are impacting mental health, but how do we measure them and how do we dismantle the power structure? So we need to grapple with really tough things, legacies of oppression, colonization, which we don't really talk about very much in the UK. We should, we need to. We need to name discrimination and racism, even though those are uncomfortable things to talk about. We need to talk about the intergenerational transmission of trauma, of advantage, of disadvantage, thinking about these as really key things that underpin inequalities. And then quickly, my third thing, do I have time? Okay, great. And the last thing that I would say is that we do need to work together. This includes being intersectional and intersectoral. So in order for us to do this dismantling, to do this really important work, we have to work across multiple levels, and we have to recognize how embedded these factors are in every aspect of life. Getting intersectoral, it means involving all sectors of government, of public life, of departments, thinking about policies that may not initially look like public health policies, but have a direct impact on mental health. I'm going to skip over the taxation example because it was really beautifully covered about progressive taxation in Michael Marmot's plenary speech. And skip to something that, as a migrant to this country, I have had some experience in working with the Home Office. There's policies that the Home Office makes that have a direct impact on the mental health of vulnerable migrants. And there are choices about family reunification policies or different ways of structuring the migration system that have a direct impact on mental health. But when we think about migration policies, it's not usually something that mental health is not in there. And so that's just one of the examples of so many of the different ways that throughout all of the sectors, we do need to think very deeply about where the opportunities are for us to think about the broader impact that policies have. I think I'll leave it there. Thank you.
Our next speaker will be Sarah.
Hi there, everybody. My journey to this stage was one of lived experience and passion. I tick many demographic boxes, and my community, I'm very proud to say, is the Ladbroke Grove community. So the three things that I'd like to focus on today are things that have helped me get to this stage and be as balanced as I can be in this day and age, which is access to nature, embedding nature into our daily lives, whether that's at home, whether that's at work, especially in care units, psychiatric units, older adult units, and also immersion in natural environments for people that don't live in natural environments. It's access to access to and empowerment through information, so whether that's knowing your rights, having choice, and knowing what's available in your area as far as community centres, activities are concerned, and knowing what you're entitled to within a service, which is something I've experienced challenges with across the board, is knowing whether a team is aware of what is available within a service and what they can deliver, because the turnover of staff can be quite rapid sometimes, and how is that translated to the service receiver, whether that's through accessible formats or whether that's just making sure that you've informed that person as to everything that they can access. And then the other question, kind of echoing my fellow speakers here, what does person-centred mean in practice? Like understanding individuality, how someone's personal life experiences translate through their engagement with the services. So I think age is something that isn't looked at as much as race, but if we think about somebody that's in their mid-60s, their experience of mental health and the stories that they may have heard would be very different to a 15-year-old. So when it comes to practicing, understanding that there's a person behind the energy that you might receive from somebody and the challenges that that person's going to be facing when it comes to engaging in their care. They're not problematic. You know, when you have a problematic individual in a care setting, it's usually because they've had some experiences that have led them to be self-protective, so understanding that on the ground.
Thank you. Our fourth speaker will be Michael.
Thank you. I kind of said it earlier this afternoon. A friend who I've been out of contact with for a long time got in contact with me, and I sent him 2 pieces that I'd written recently. One was an opinion piece in The Guardian about our fuel poverty report, and the other was an essay in The Lancet, which I entitled something like Lower Taxes or Greater Health Equity. And my friend came back, because I said we'd been out of touch for a long time. He said he really liked the Guardian piece, but he really didn't like the Lancet piece. And I was mystified by this, because I thought they both said, I only have one theme, I only have one thing to say, and I just say it all the time. How can you like the one place where I said it and you didn't like the other place? What he commented about my Lancet essay, he said it was regressive. Yikes. The penny finally dropped because I used the word equity. He said, you're indulging in old-style politics that never got anywhere. The debate, so-called, between people who want lower taxes on the one hand and want greater equity on the other hand is a sterile debate that gets nowhere. I then went back to him and said, what I mean by health equity is those systematic inequalities in health between social groups that are judged to be avoidable by reasonable means and are not avoided, hence unfair. So he relented a bit. We've still got an argument to continue, I mean a constructive argument to work out, but he relented a bit. But the reason I tell this little story now is that if we approach government and say, we want greater equality, and government says, we want greater freedom, and what my friend is saying is that sterile debate got played out through the whole of the 20th century and got nowhere. I think what we want is to address the injustice that some people are not living lives to their full potential through no fault of their own. I think that's the key point. That's what I mean by health inequity. Not that everybody should have everything the same. That if some people, and I come to Amartya Sen, but I'd never say that in my 3 minutes of the politician, that justice means that people, we create the conditions for people to lead lives they have reason to value. I can't tell you what is a valuable life. I can't tell you what is a valuable life. But we want to create the conditions for you and the people you work with to lead lives they have reason to value. And if we do that, we will get greater health equity. So we've somehow got to get beyond the debate of, oh, I'm for freedom, I'm for equality, and we talk past each other, to say we want greater health and well-being for everybody. And to say it again, if people have diminished lives through no fault of their own, through circumstances outside their control, that's a sad judgment on all of us. And what I showed you earlier this afternoon is we are in a parlous state. Health has stopped improving. Inequalities are getting bigger. Health for the poorest people is getting worse. And this is a very sad statement about the fifth richest country on the planet. It's time we did something about it.
Just remind what the question is. So what factors should governments, policymakers and public health practitioners prioritize to reduce inequalities in mental health outcomes? Our next person to respond to that question is Kadra.
Thank you. What tough acts to follow? So I just firstly want to preface what I have to say and really echoing what the other speakers have already touched on, that inequalities in mental health often don't exist in silos. Many of them really do overlap, and these compound many of the known risk factors for poor mental health. So whatever action we do hope to take, we really can't take a patchwork approach to this. So I just wanted to touch on 3 areas we've been campaigning on at Centre for Mental Health. The first factor, and there's already been lots of discussions about this today, is I would really like to see decision makers, practitioners and researchers acknowledge and work towards eradicating racism and racial inequality. I think the evidence base is really clear that racism is toxic for mental health, and it can have a really long-lasting impact on people's well-being. Lots of presentations today have been shared about the impact of racism on common mental health disorders. And I think one thing that we're beginning to understand increasingly, especially over the last sort of decade or so, is really this conceptualization of daily experiences of racial discrimination as racial trauma, because really many of the symptoms people present with can be likened to post-traumatic stress disorder. And this is something that not only affects the person that is subjected to racism themselves, but it's a collective experience, and many of us, experiencing this vicariously, even, to think about the murder of George Floyd and how that impacted people across the globe. So this is a collective trauma in many ways. It's also important to note that structural racism itself exposes people from racialized communities to a much greater extent to many of the known risk factors such as poverty, poor housing, unemployment, and I think it's really clear, and the evidence has stated this, that race and ethnicity themselves are not risk factors for poor mental health. So really, we need to conceptualize racism as a risk factor for poor mental health. And I think I read a paper a couple of years ago, an American paper that looked at all the conditions set out in the DSM-5. There's 300 disorders in there, and not one of them really recognize racism as a stressor for poor mental health. And I think that's, really telling in some ways. We've heard presentations today about showing how racial discrimination prevents people from being diagnosed properly, from accessing appropriate care and support, and from benefiting the treatment and care that everybody's entitled to. And I think this is really a shameful injustice, and we should all be concerned about it. So the other significant inequality that threatens people's mental health that I wanted to touch on as well is around financial inequality. And again, that's come up in quite a lot of the presentations and remarks from speakers here today. But I just wanted to specifically focus on the experiences of children and young people, because that's my area of work. Really, all the young people we're speaking to recently, this is coming up time and time again, the impact of poverty, growing concerns and worries about the cost of living crisis, and this is really something that they feel is impacting their mental health. We know that financial inequality increases people's likelihood of developing mental health problems, and for children, that risk factor is fourfold, which is quite concerning. But there are, lots of proven methods and measures that if you take people out of poverty and reduce the income gap, you really do lead to better kind of mental health outcomes for them. So at the Centre for Mental Health, we've been calling on government to address financial inequality by improving labour market and social security measures. For example, encouraging organisations to adopt the real living wage standard, to boosting people's social security, One example of that might be a decision that was taken by the government in 2015, I believe, to introduce a 2-child limit for child benefits. If that was reversed, it would immediately lift 250,000 children in the UK out of poverty, therefore protecting their well-being. Another thing that we need to reintroduce is child poverty measures as well. That's something that was unfortunately dropped by previous governments. If we can't track it, we heard a lot again about the importance of data in helping us understand and monitor inequalities. And then finally, but certainly not least, the other sort of factor that I wanted to touch upon is really recognising and addressing the physical health inequalities faced by people with longer-term mental health conditions. Why? Because estimates show that there's an average of 15 to 20-year shorter life expectancy for people with mental illness, and this is predominantly due to a range of physical health conditions that get neglected by health services. I think from my perspective, it's simply unacceptable that people with severe mental illness are 3 times more likely to have diabetes, twice as likely to have heart disease, and during the pandemic, there was also a 3-time likelihood of them contracting the COVID virus. So there have been, I think, some welcome steps in this area. More recently, for example, NHS England, as part of their long-term plan, committed to introducing annual health checks for people with severe mental illness. And I think there's really positive learning from the rollout of the COVID vaccine program and how that people with severe mental illness were prioritised as part of that. So yeah, I'll leave it there, I think, for my 3 points. Thank you.
So our last respondent to that question is JP.
Thank you. Really hard act to follow on this panel. I'm going to take a slightly different tack. So, underserved populations are being systematically excluded and neglected from research and practice. We've known for decades that racialised groups, and you've picked this up in your response, people from black and other minority ethnic backgrounds are much more likely to experience coercive pathways into care, much more likely to come into mental health care through police and other involuntary routes. At the same time, we know that there are a range of evidence-based therapies that can help to keep people well, and these are offered to the same groups of people at a much lower frequency than white British people. So these are pervasive inequalities that we've known about for some time. We've known about it because of groups of dedicated researchers who make it their business to try and find out about it, alongside advocates and campaigners. That's how we've known about it. But actually, this should be part of our infrastructure of what we do. So data, we're in such a great place in Britain. I think this was raised by Professor Marmot earlier. We have some of the best data resources in the world. We've got cohorts, we've got cross-sectional surveys, we've got healthcare records, which can give us real-time insights into mental health care. And yet, we fail, even in our data collection in the UK, to really understand properly about these groups of people and their mental health. So just to give you 2 examples. National surveys, they're fantastic. I can see Sally sitting there at the front, and her and others have led the way with repeated national surveys that are representative of population mental health. They give really powerful snapshots of mental health that can really inform policymakers. Now, they're nationally representative, but for minoritised people, we don't get enough information out of those to be able to make the same sorts of decisions that happen for the general population. So they're nationally representative, but they miss out essentially the groups of people that potentially have the worst mental health outcomes. A second example are healthcare records. Healthcare records are brilliant because they're real time, they tell us really what's going on. We saw in the COVID-19 pandemic, they provide really useful insight, and they're the sorts of records that get generated when people make contact with their healthcare providers. So wouldn't it be cool if we could use those data sets and use it to really inform and improve the way that we as clinicians or commissioners of services provide care? And yet, ethnicity and other protected characteristics actually are just poorly collected. If you look across the country, they're collected in a patchy manner, and sometimes there are big issues around the quality. And these are sort of simple things that I think at a policy level could be addressed that could really put the data to work and make it work for better care. And I want to just finish by saying that involvement has got to be part of this. So we tend to think of data as being a separate thing, but actually data is our data. We need to make sure that our solutions and our approaches are inclusively developed, so we do it in partnership with the people that we're talking about. So I don't have one or two or three suggestions, just a wide-ranging plea that I don't want to be talking about this again in 20 years. We're at the cusp of something really amazing where things will change. There are moves to change things. There are things on the horizon, but I don't think this should be coming through campaigners. It needs to be built into the infrastructure of what we do in everyday practice.
Thank you. Thanks, everyone. While you start thinking about the very clever questions you're going to ask our panel, I'm just going to start us off with a few. This question, I think a few of you could answer, but just sort of thinking about, lots of people talked about racism and inequalities. And I think part of the things, Jyoti, that you mentioned, like that ethnic minorities are less likely to access the system, also come from a long sort of decades of experience with the system, which is essentially, we learn not to trust the system because the system has underserved us for so long. So in that context, how do you create a more inclusive health service, especially around mental health, where the biggest, you could argue that one of the biggest barriers was actually that the health service cannot be trusted by the people who need to access it. Does somebody want to go first?
So, in responding to that, I think something that we often forget is that the National Health Service, where many folks are receiving care, whether that's related to physical, mental health, or other types of health, it is a part of the state, and therefore perception of the state will also impact perception of the National Health Service. And so when we're talking about people experiencing mistrust or difficult or challenging services within the NHS, it's not just the NHS, it's not just where they receive healthcare. Those experiences are shaped where they receive social care, housing support, welfare support, policing. All of these things ultimately are apparatus of the state, and we shouldn't shy away from that discussion, because I can see on a local level where we run our adult counselling services and these kinds of things, 95% racialised communities who are accessing that service. And people come to us and they say, oh, that's such a high percentage, these folks don't access our services. It's like, yes, because we're kind of building our house in a slightly different place. We're not intrinsically linked or being perceived to be intrinsically linked to other parts of the state. And so for me, we can't separate the places where many of us receive healthcare from other experiences that people have of the state.
Yeah, I can build on that. I guess from the children and young people's perspective and families, one of the key messages I often hear is that they want choice and a voice. And when we think about access to support as well, we need to think beyond the NHS. So just about 35%, I believe, of children with a diagnosable mental health condition receive NHS support. Actually, a lot of the support they receive is out there in the community. So I really think, instead of us thinking about why aren't they accessing our services, we need to really be going to where communities and young people already are. There's some fantastic examples we've looked at, like a charity called MAC UK in London, where they offer street therapy for young black men, and they literally deliver it in clusters and wherever the young people are. And then I think really thinking about organisations like Taraki, there's so many organisations led by people from racialised communities that may not necessarily have mental health as like a banner. I really think we need to fund them, we need to respect them, and we need to be working more in partnership with them.
I can build on that point too. I've been really inspired by so many of the talks and presentations during this Congress where people with lived experience bring their perspectives. And for me as a sort of quite traditional researcher, it really changes the way you think about things. So what I would like to see, and I think there are moves for this to happen, is bigger co-production around how we develop and provision our services. There is a patient care race equality framework which has been going national at the end of the year, where that is one of the central objectives. And if we manage to achieve it, and there are lots of, let's not be naive about this, we're talking about deeply entrenched inequalities, inequities, that go back decades. But if we manage to achieve it, then potentially we may be in a better place where services are much more acceptable, where communities feel that they can seek help if they need to seek help, where care is being delivered in a more equitable manner. That's my optimistic response.
Yes, bigger.
Yeah, just actually to add on to that, I think really this patient-centered emphasis that's come out from so many sessions is really, really key. Thinking of what outcomes are meaningful to people, and moving away from paternalistic decision-making where a clinician is imposing what they believe should be the outcome, should be the life that they think that the patient should have. But I also think that we need to consider how available appropriate and trauma-informed services are, and just trying to set up our systems to be a lot more sensitive to people's whole life experience when they're coming to a service. It's not just one thing that's happening. There's an entire personal history that affects how they access care, and then also the outcomes from the care.
So in other words, people are not
People are important, yeah.
Yeah, I'm just going to echo, going to communities and not expecting communities to come to us, and not using terms like hard to reach. It's so frustrating when I read stuff like that. I've worked in an advocacy charity where it wasn't embedded in our contracts that we do translated formats, and that we would go into places of worship, community centres in order to engage. Yet we were promising diverse engagement within the forums that we were creating. So that on a structural level, it exists in charities. And then I mentioned I'm from Ladbroke Grove, and so some of you may make the connection that I'm part of the Grenfell community. And after the fire occurred, our take-up with the specialised mental health services that were created in response to the fire, the take-up was so low. But there was huge community support internally, and what was deployed was counselling and support services within the Almanar Centre, which is a mosque and a cultural centre, and in our community centres, but they're under-resourced, and they're under-financed, and they're under-skilled. You're expecting people that don't have the expertise that we have in this room and in the NHS to be holding space for people who have complex trauma. And that worries me. So I want community to be embedded in the way that we engage, but equally the community themselves, the people delivering that support in the community centres, need to be supported and skilled enough to be able to hold that space safely for themselves, so that they don't end up taking on that kind of ripple effect of trauma. So.
Thank you. Thanks, everyone. So I'm going to ask this next question, and Michael, this is going to be for you to start the answer with, which is, obviously you have many decades of experience of trying to make inequalities an issue, try to reduce them, and, many decades, and the inequalities are only widening. So I suppose, to us younger folk, what are the lessons, if you were starting again today, what are all the things what are the things you wouldn't do, and what would you do instead? To try and actually, that in 30 years' time, we're not just having this conversation again.
Well, the first thing to say is that it's not true that we've made no progress. I commented, forgive me referring again to our fuel poverty report, but one of the comments I got was, you can't tell me that growing up in a cold home is bad for children's mental development. Why, when I was a lad, we had ice on the inside of the window, and look at me. And my thought was, if you'd grown up in a warm home, you might have achieved something really special. But more diplomatically, I said, when you were a lad, infant mortality was 30 per 1,000 live births. Now it's 3.4. The fact that you survived when the rate was 9 times higher than it is now, doesn't mean it was either desirable or acceptable. And if we look at the inequalities in infant mortality, in 1950, it was something like, don't quote me, you can quote the 30, that's correct, but I'm making up the next figures, so don't quote me. But it was something like 12 in the best off group and 40 in the worst off group. Don't quote me. But it was that order of magnitude. Now, in the worst off group, it's 5. Less than half of what it was in the best off group in 1950. And in the best off group now, it's about 2.5. It's still double, but the difference is 2.5 per 1,000 live births. We made enormous progress. So there's an area of health inequalities that we really, really made great progress. Now, there's a worrying blip up in the lowest socioeconomic group of infant mortality rising a little bit. Inequality is growing, but still, let's put it in the context of the progress we've made. Second, if we look at adult life expectancy, when the last time government was interested in listening to me, and I said I'm not party political, was when Labour were in power. And I was a bit critical because I said, you haven't made that much progress. You wanted to, but you haven't made that much progress, which is why I was commissioned to do my Marmot review. Because they said, well, tell us what to do to make more progress. Now when we look back, if you look at life expectancy for people living in the poorest 20% of areas compared with the rest, during the New Labour period it narrowed. And after around 2012 it started to widen again. So there's an example. Labour, and I'm not a supporter of, like New Labour, Iraq War, I'm not a supporter, I'm not making a political case. They took 500,000 children out of poverty. That's pretty good. You may think Blairite scum are the worst people in the world. They took 500,000 children out of poverty. I remember talking to Ed Balls at the time when I was doing my 2010 review, and said, you said you're going to abolish child poverty. The definition of child poverty is less than 60% median income. You've got no understanding of statistics. How can you abolish it? There's always going to be people below the median, so you're not going to abolish it. He said, well, that's our most ambitious target. Okay, so they didn't abolish it. But 500,000 fewer children grew up in poverty. And as I showed you, it's risen again. So the lesson is not, oh, it's all hopeless. I've been banging my head against the wall for decades. You can really make a difference. Put your mind to it. Say this is high priority for us to get greater equity. We think it's very bad to have children growing up in poverty. We'd like to be like Finland or Iceland or the Czech Republic or South Korea and have 10 or 11% of children in poverty, not 29 or 30%. You can do it. You can make policy changes. But, and the reason in my talk I finished with local action, because I don't think there's anything rewarding about banging your head against a closed door and keep banging your head and saying, gosh, it's still not open. That's a very unrewarding experience. So push on a door. If it doesn't open, I push on another door till it opens. And local government are opening their doors all around the country. Various faith community organizations are opening their doors in different parts of the world. So let's work with the people who really believe in social justice and health. And that's why when people say, aren't you demoralized? I'm not the least bit demoralized. It's not just because I had a secure childhood and loving parents. It's not not just a personality thing, is because there are good examples of people really making a difference. And if they're not doing it at national level, then let's do it at local level, or let's do it at supranational level. And the demand, I can tell you, the demand for the kind of insights that the Institute of Health Equity represents is huge. There are people all over the place that want to know about this and want to do it. So what I've learned is that there are people of good faith all over the place. You find them in strange places, in weird parts of Birmingham, for example. You find people all over the place who really, really want to make a difference. Let's work with those.
Okay.
Can I add to that?
Yeah, add to that. And then we're opening up for questions. So the next person who's ready to ask a question, go find a mic, please. Thank you.
I just wanted to add to that because I think that is what gives me hope, is that recognizing that things like unpicking poverty, we can work with people that are working in poverty, and that's going to have an impact on mental health. We can work collectively with other social movements, and that's the exciting thing about when we look at environmental justice activists, and when we look at all of the action that's happening in terms of ensuring racial and ethnic justice. We can work collectively with these causes, these organizations, these movements, because fundamentally we share the same goal of creating the opportunity for people to have lives that they value, lives that that are meaningful. And so I think that that's an opportunity that we have, and I think that the recognition of this and how we can work together with existing social movements is hopefully growing in mental health, and realizing that we're not just siloed off from everything else that's happening in the world.
Can I add to that quickly as well? It can be quite daunting being somebody identified with lived experience at places like this today, because all these statistics are coming at me that I'm working tirelessly to try and prove wrong, like I'm not going to die 20 years younger and I am going to be great and all of these things. But we can lose sight of the timeline, and maybe that's something that we can introduce into mental health practice as a woman. You know, if I'd found myself in mental health services 50 years ago, I may have never come out. You know, and if I had come out, I may have not come out with my reproductive organs. And when I work with service user involvement groups that I've run in the past, when we feel really overwhelmed at the challenges we face when we're going into meeting spaces to try and advocate as one person with 20 people around a table, that's something that I bring up. It's like, let's step back, let's zoom back and recognise that a lot of change has occurred, but that we keep going. So maybe that's a narrative that we can start practicing in practice.
Who would like to ask a question?
I seem to have the microphone. So I just want to say I'm completely in awe of everybody's vision, and it makes you want to become an activist or a politician, but I don't think I'd be very good at either. And so, as a researcher, I guess my question draws a little bit on what Jay was saying. There are some forms of data that are not being collected consistently, and so my question, I guess, to anybody who thinks they can give an answer is, what kind of data should we be collecting? What kind of analyses as researchers should we be doing that's going to get the message across to politicians? Because if we're taking a public health approach, then essentially all of your great ideas with working in the community, it's going to take funding. So how do we convince the government, I suppose, and get activists who really are good activists to support it and to get the message across, to make those changes and use the data that we can collect and analyse?
Do you want to go first?
I can take that question first. I raised all the great data sources that we already have in the UK, and there are sort of big gaps. I mentioned national surveys. The last nationally representative survey of minority ethnic people was done in 2000, right, so 22 years ago, a generation ago. And in the absence of these sorts of surveys, we're sort of hamstrung with, how can we use what we have to really understand what is happening, what's the landscape. And it's constantly changing, and I'm going to talk about ethnicity and race because that's what my sort of opening salvo was about. But, we have to think about what are the sort of indicators, what would good look like, and how can we essentially co-produce that with the impacted communities to kind of measure it. But equally, we need to also be using data sources and pushing to get that data collected so we can then use it to inform on what we do next. And health records, for example, could be one place to do it. I should mention, I don't know if I'm allowed to mention this, but potentially we're moving towards another boosted survey. So just to pick up a point around optimism, some things are changing, but I think as they're changing, we really need to think about how do we involve impacted communities to really make a difference, right from the beginning, not as an afterthought. I don't know if I answered your question.
So just a very kind of real-life example at the moment that we're facing locally. There's a huge challenge locally where I'm in Birmingham around exempt supported accommodation. For those of you who might not know what that is, essentially those who are particularly vulnerable, may come out of prison, serious mental health challenges, learning disabilities, fleeing violence. It's a supported type of housing for them to live and hopefully, ideally, flourish. Unfortunately, that sector is an absolute mess with very, very low levels of regulation and a lot of exploitation taking place. Birmingham is one of the hotspots for that in the UK, and the area I'm in Birmingham is one of the sub-hotspots within Birmingham. And we found it's very difficult in ways to kind of knock on the door and make your case unless, you know, the data that you have is compelling. And so when we go and say there is a cluster of these properties here that are causing challenges, this is no way good for tenants in those houses because they can't flourish. You know, we get told actually there's clusters here, here, and here as well. But then we put one other layer of data analysis onto that, and that is about serious levels of crime. And so then we see, you know, this cluster here, actually there is huge amounts of serious levels of crime compared to this other cluster here where there isn't. And so that helps us to make a slightly different, more compelling case. And one thing that I'm looking to try and do at the moment, and this is a call to action for anyone in the audience who's interested, is I want to overlay health outcomes data on top of that as well, to try and understand and try and make the case to planners and to people in policy, why are we allowing these clusters of housing to develop here, where there are already existent inequalities within health outcomes, there are huge amounts of serious crime and other kinds of challenges. Is it responsible for decision makers to allow more of these accommodations to be put here? And is it actually neglect towards the tenants of those houses as well? And so sometimes we have to kind of try and overlay these things, but just as my colleague mentioned as well, sometimes kind of community level resources, I've got no idea how to do a health impact analysis on kind of overlay it with housing. But you know, these are the skills that we can have, and these are the skills that we can be sharing with our communities where they need it, to actually try and bang on the door and ultimately support communities to empower themselves through data and make their case for change.
Thank you. Michael?
I'm a data nerd, so I love data. But may I read you Article 1, Section 2 of the Constitution of the United States? Declared that any person who was not free would be counted as 3/5 of a free individual for the purpose of determining congressional representation. In other words, African Americans counted as 3/5 of a person. They had no rights. The reason for the 3/5 clause was so that the slave states could get increased congressional representation. I looked at some economic data recently, in the current economic data. For every dollar that a white man in the US earns, an African American earns 60 cents. Oh my God. The 3/5 clause is alive and well, living 200 and something years after the Constitution. So data can be misused very badly, such as the 3/5 clause of the Constitution. On the other hand, making the case that this structural racism is still going on that a black man is worth 3/5 of a white man in terms of earning potential right now, not in 1788 when the Constitution was written, but right now. Those data are very powerful. So as a self-confessed data nerd, we need data. But we need to make sure who controls the information and the purposes to which it's put. And the point that you made about data coming from the community, not having data as another mechanism of control, I think is vitally important. But I don't want an evidence-free zone. I want all the data that we can that's highly relevant to the topic we're talking about.
Sarah?
Yeah, something I've been thinking about, I'd say for about 2 months now, is inherited strengths instead of inherited trauma, because I'm fed up of thinking that I've inherited generations of trauma and that I'm experiencing trauma in my day-to-day. And so I thought about inherited strengths. So that's cooking, that's music, that's art, that's coming together, that's dance. And again, I live in Ladbroke Grove and we just had Notting Hill Carnival and we haven't had it for 2 years. And for the community and for those that flock to it for the right reasons, it's so much more. And I was, I was in a feedback forum last night with the community and the council, which was interesting. It's not a street party, it's a carnival. And carnival has heritage and carnival has survived. And so let's start researching inherited strengths. Let's start researching why our communities are still here and beautiful and flourishing in spite of systemic racism, and not why we're dying because of it. I think a great practice that's doing the research that hasn't done it for ever is the arts and health world. So I'm an arts and health practitioner, and we always struggle to get funding for projects, even though we know it makes a difference, but it's because we didn't collect data. So a good example, hospitals, Chelsea and Westminster, they have their own charitable trust. They were lucky enough to be situated in Chelsea, and so when they opened up the hospital and created the charitable trust, they had wealthy donors, basically. So they have a lot more funding to play with when it comes to research, and there's some really exciting research happening under their umbrella. And because they're connected to the hospital, they've got, a playground to play with. So one of the things they were researching was imagery in triage spaces in order to minimise trauma of being in the triage space. So they looked at what types of imagery worked best. I don't know what the research determined because it was ongoing when I spoke with the person there. But arts and health is a great field to look at with this, because we didn't do it for a long time and we're starting to. And we're starting to gain traction and be recognised as a therapeutic healing practice that can sit alongside pharmaceuticals.
Thank you.
So I am also a data nerd. I'm an epidemiologist. I think I'm in good company that we have a lot of data nerds here. But I think the thing that's become very clear when we look at the response to the COVID pandemic, for example, and many other examples, but that one's just so crystal clear that it's not just data that matters. I wish that it was sometimes. I wish that we could give policymakers, government officials, a clear data. We have a clear pattern. We know what works. We know the sorts of things that we need to invest in to make a difference. And if we just had the perfect data, if we just had the right data, then things would happen. But we know that that's not a direct translation. So I think that we need to partner with people that are experts in knowledge exchange. We need to learn how to. There is that art of communicating about science that I think we need to be a lot better at. And we also, we are used to communicating our findings in academic settings, but I've loved having the conference more open to people with lived experience, and that's enriched the experience, but it also is changing the way that we do research. So I think that's the first point. And then really quickly as well, as Michael said, data can be used very badly. And data can be used and embedded as a tool to just exacerbate inequalities. So when we think about big data, when we think about machine learning and the growth of artificial intelligence, there's a lot of assumptions that are built into models. There are a lot of decisions that serve to reinforce and even exaggerate inequalities. And I could talk about this for ages, but I just think it's really important because data could also be used as a tool to fight against structural inequalities, but we just actually need to be a lot more transparent about what's going into the machine and what's coming out of it. So, and just, just being really aware of that.
Thanks.
Thank you. Disclaimer, I'm not a data nerd, sorry. But I wanted to make a broader point. I think, we're all striving for parity of esteem between physical and mental health, and one of the areas where we see a huge discrepancy is in research funding for mental health research. I think, of overall health research funding, it receives like a tiny proportion, and that's, a worry and something, we need to address. I think also as researchers it's really important to really critically interrogate and adopt an anti-oppressive approach when we're looking at data. Coming back to ethnicity and what we know about children and young people's mental health, the research tells us that they're least likely to present with mental health problems when they're children and young people, and then all of a sudden they turn 18 and then that data just suddenly flips, and we just seem to accept that and not really challenge it. And then I wanted to say also that there's a lot of evidence relating to mental health and well-being in other data sources and in other sectors, thinking about the criminal justice system, the immigration system, education system. These are all important sources of data and insight for us. And then lastly, I think something that's really important to recognize is the gap between research and getting that adopted into practice. I think there's a 10 to 15 year gap. So what more can we do as researchers to really translate that insight into actionable insight for people on the ground so that that can, quickly kind of be adopted if it's, something that's deemed effective.
Thank you. I'm just going to add a last thing to that. This is taking inspiration from Sally yesterday, money. So if you can translate what it costs society, costs people, costs the health system, maybe you can sometimes make better cases to policymakers. I'm not claiming it always works, but it's worth sometimes trying. Okay, next question.
I'm going to try to make it as simple as possible, and I don't know how it's going to go down actually, this question. It's a bit strange. I'm not a researcher, I'm a lived experience delegate, and I would like to describe you something that happened in Portugal a few years ago, and then I'll explain why this is relevant. So the government decided to build in Algarve, some of the area, the southern area of Portugal. The whole area, the whole south is called Algarve. It's a whole regional area like a shire. And across the whole area, the government decided to build a new road because the old road was non-usable anymore. It was dangerous and it was in a bad state. And the population had been asking for this to happen. However, once the road was built, it was higher quality, it was brilliant. However, they put charges on it. And the population got so upset that they got together, all of the whole south got together, and they didn't go on the road until the government actually made it free. And now it's a free road. And we'd like to launch sort of a challenge. How would you design an intervention that would mobilize the population like this in terms of changing the inequalities that are happening in public mental health?
Okay. Who wants to take that first? Big challenge.
Amazing question.
I'm happy to give it a go.
Thank you.
I'll just maybe touch on one example of a program that we're involved in called Young Changemakers, and that's exactly what we're trying to do. So this is a program seeking to reimagine mental health support for young people from racialized backgrounds through social action. So our role really is as organizations facilitating that process, equipping young people with the tools and the resources they need to design campaigns either at the national or local level on matters that matter to them the most in mental health. And it's been really an interesting process, giving them all that sort of tools and knowledge. One group of young people decided they wanted to call for mandatory anti-racist training for all teachers in schools, and they've launched and designed their own petition and social media campaign around that. Another group of young people decided that in their community there wasn't a strong sort of awareness of youth mental health and how it impacts young people, so they designed a series of workshops, and we supported them to kind of deliver that. Another group focused on GPs and the training they receive. So I think that all of us can do things like this if we are committed towards it and put resources behind, and we hope to see these kind of initiatives kind of become more sustainable and more widespread as well.
I just love this question. I think it's brilliant. It made me think of a presentation that we had yesterday from Martine from Lebanon. I forget her surname. And she was talking about the impact of participating in collective action. So she was talking about protests that happened in Lebanon, and was really saying that there seemed to be a bit of evidence that being involved, being a person that stood up and was involved in these collective actions, whether it's for human rights, whether it's for racial justice, whether it's for environmental and climate change, that seemed to have a benefit to people's mental health. So I think it's exciting because we could do things together to get farther and to move the needle on a lot of these things. And I don't have a good example, but I just wanted to thank you for that question, because I think it really is, it's a great one.
I'm going to have a go. I think it's a great question, and I guess it's good to hear all these responses as well. For me, I think your example of essentially collective action is kind of where power and where the power sits is being challenged. And if I think about inequities in the system, some of this stuff gets replicated because those power imbalances are very difficult to shift. It's a very small point, but I think if you had more leadership of people in some of these systems, that could help with mobilising action. We had a great talk in the earlier session around the multicultural psychiatry group, so a group of trainee psychiatrists working together and with involvement experts and working with local communities to co-produce approaches to tackling racism in the mental health system. So collective action is great because it feels like if you can just harness it, but for me it feels like it needs to be embedded at every single system, because the point that you raised, Jen, is we can have the data, but actually we need to put it to work. And so it feels like we need a shift in the people that are making those decisions, and I guess it all links back to capacity building and so on and so forth.
And a shift in the people who do the research too.
Can I ask the asker if you have any ideas?
Could you repeat?
Do you have any ideas? Did you ask the question with a template in mind, or were you just posing as a fantastic question?
I just think it's an amazing example of having a population, a full population doing something because they didn't like what was happening. There was no civil war. There was some turmoil, but there was no civil war, and it was changed. They simply didn't use the service, that's it. Service is here, use it, you have to pay for it. No, we're not having it. We will use the old rules. That's it. We'll keep dying on the road. And it worked. It did work. I wonder how that would translate in some of the... Well, I wonder if so many things. I mean, I heard so many people talking about their own research that they do with their teams. There's so many teams, and you are all pulling into one direction within your own particular interests. However, Professor Michael Marmot did talk about all-encompassing situation that's happening in society at the same time. All this is happening at the same time. Why don't you join up?
Can I just add one really quick thought to that? Okay. I think one of the just practical things, and it could be applied in so many different settings, is speaking up when you see injustice and then amplifying those voices, and so we can avoid being bystanders when we're seeing injustice happening, and then we have to take responsibility also for combating injustice when we see it. And so I think it is our own responsibility. And then when you see someone that's standing up for injustice, then you can join them, and then we can become stronger together and be pulling in that same direction, rather than being competing for accolades or the spotlight or whatever. We can actually start to move forward together.
Thanks, Jen. I second that sentiment, as we all already probably know. Brilliant. Does anybody else have a question?
I just wanted to follow on from the conversations that we've been having. I am a data nerd, but also I'm now a stories nerd. As Brené Brown says, stories are data with soul, so I'm adding that to my nerd companion. Look, I think language is really important, and I wanted just to speak to sort of at this point in a conference it can feel overwhelming, and there's so many things we could change, and I'm a bit of a pragmatist sometimes, and I think about collective impact and collective action and what we can all do. You know, if everyone here just does one thing, what can you do? Yes, you can advocate, but I think as researchers, and many people here are researchers, language is very important, and if we're opening up conferences like this more and more to people with lived experience, then every single person who's speaking needs to think about somebody in the room listening who's got lived experience and the implications of what they're saying. So I see we're very good at declaring our conflicts of interest now when we present at conferences, but I would challenge us to also be thinking about the way in which we talk and communicate to respect and honour the perspectives of people with lived experience. We must make these conferences safe in doing that. And the second thing I wanted to also say, something that I do, and if you want to take this up, please do it, is when I'm asked to review journal articles, which somehow I seem to get an enormous amount of requests for journal articles, I've started creating my own little subheading that's not asked for by the editor, which is language and the way it's communicated. So I have a little section that if I think that it's not being strengths-based, if I think there's implicit discrimination and racism within the way that the article has been written, I comment on it. So I think more people can do that. So that's my challenge to you if you're doing those things.
Thank you. In the spirit of that, shall we ask our panel to all add like challenges of things we can do as researchers, as part of the public mental health community? One or two things we can do to make things better. Do you want to start?
Well, I'm going to slip away.
Oh, yeah,
so
okay.
Not
Thank you for
avoid your
joining.
question, but as I slip out the door, I just want to say that there are plenty of reasons to be miserable and down in the mouth about our current situation. But the question you asked me earlier about what I've learned from experience, what I've learned is, in the past, it's been extraordinarily difficult to get people concerned with mental illness, with cardiovascular disease, and so on and so forth, to think about prevention, specifically, or more generally, to think about social determinants of health and health equity. Do you know how encouraging this whole afternoon has been for me? It's just wonderful to have this as a theme of the meeting, to have all people engaged and asking practical questions. How can we take the general approach and make it concrete and tangible? This is fantastic. This is really brilliant. We we are changing the world. So will you excuse me?
On that happy note, we're all now going to talk about how we're going to change the world. So Jen, you can start.
Okay, great. I think one of the things that has come out really clearly in our discussion today is the power of the collective experience, and also how we need to be a lot more person-focused and story-focused, and really taking that perspective into the work that we do. One of the things that this has made me think of is one of the projects that I've been working on. We worked with a team of peer researchers, and one of the things that they had us reflect on was how all of us, as researchers, as people coming to a research project with lived experience, we're all coming with multiple identities, and we don't just have one label, we don't just have one role. We need to think really cohesively about how we're coming to research with a lot of different identities, a lot of different experiences, and how that shapes us. So I think that maybe acknowledging that us researchers aren't just pure data nerds who are just objectively analytical, but that we are bringing sometimes implicit biases, sometimes our own opinions and stories that we've carried with us, and how that affects our research. So maybe embedding a little bit more reflective practice into something analytical like epidemiology would be something that could shift the conversation in research.
Thank you. Shiranjit?
So from my side, I'm going to take inspiration from a parent. And the reason I do that is very similar to what was mentioned about inherited strengths, in terms of what has been passed down, which fills us with hope, with optimism, with a willingness, with a push, with a drive to seek social change. And one thing I think we can all do is, after today, within our teams, individually, take time to reflect on your collective values. Values was a word that was used a lot during my upbringing. Take time to reflect on your collective values, what that means for you individually, what that means for you as a team, what that can mean for how you engage with the world more widely. Your values will help you to develop that reflective practice. They'll provide you with a toolbox to look and reflect and change how you interact with the world around you. And importantly, your values will potentially fill you with that hope, with that joy, and with that drive to make that change more widely. And then just think about the skills that many of us have, and where there is a distinct need for some of these skills, and think about where you best fit in that jigsaw puzzle. And one of the challenges I find when I work with folks in the academic space, and this is coming from someone who's 1 foot in the academic space, I get main character syndrome sometimes. It's not always about us. You know, we are a jigsaw puzzle in a huge, huge, complex puzzle of various different layers. And how can we be that piece in a place that needs that support that we can offer? But for me, it all starts with that reflection of our values.
Thank you.
Yeah, my response is maybe more connected to care delivery. So during the pandemic, I was working for an advocacy charity, and we set up a personal health budget service in Hackney, and working in partnership with the NHS under a charity. And I'm sure many of you, if you're not a practitioner, know practitioners, you know the mental health of the NHS is struggling itself right now. People are exhausted. Burnout doesn't even begin to explain what people who have been working on the front line are experiencing. And I was hiking with a fantastic charity called Mind Over Mountains. They're brilliant, look them up. And I was talking with a practitioner who was asking me, what can we do? And part of what we were thinking about internally at the charity on a union level, because it just feels, it was quite hopeless for quite a while. was looking at just actually doing what we've been contracted to do and not overperforming and bending backwards and over-delivering on budgets that were never going to be, were not set realistically anyway. So self-care, self-care when it comes to being yourself as a practitioner or a researcher or somebody with lived experience, doing your day's work and then looking after yourself and not doing overtime, adhering to contracts and as people have said, self-reflection around did I play into the systemic inequalities today, and if I did, what could I do differently? But just on one practical level, like stop doing overtime if you're a practitioner, because then that's when it's almost like that's the step before striking, because we can't not deliver care. I think that's the challenge in the care sector. We want to say something collectively to the powers that be that fund the system, but we can't stop doing what we want to do, which is care for people. But we can care for them in the time that we've been paid to care for them, and then go and look after ourselves. So that's what I'd say.
Thanks, Sarah. I know you said specifically to clinicians, but I think this really applies to all the academics in the audience too. So I think the message is, whatever you're doing, but thank you.
Yeah, because if we're always over-delivering, we're always going to be underfunded. If you get what I mean? Like, sometimes it takes a burn for people to recognise, oh, actually, you've been doing way too much or way too little. I didn't realise. Next time, maybe I'll give you a bit more money. I wish it was as simple as that. But.
Thank you. Debbie?
I guess, Praviti, your question's about social change, and for me, the change element is kind of the excitement of, how we can use our methods, our science to really inform that. And I suppose if we, I guess that's kind of, it's not a science that's existing in a vacuum. We're all doing essentially politics to an extent. Every time you publish a paper that, establishes people with severe mental illnesses dying 15 to 20 years earlier than the general population, or the prevalence of gender-based violence, or about inequalities or inequities in access to treatments. We're all doing politics, but for me, the way that the change, how we get that data out of the papers and get it to work, to maybe push for that change, there's a big gap. And I wonder if the thing to take away, certainly I take away from the last 2 days of this conference, is a sort of flexibility in how we think about these things, in terms of bringing in the expertise of people with lived experience to inform that then starts to, and then to give back in a similar way that can then help advocacy in the community to push for some of that change, or thinking about storytelling to put that across, which can also get our data out of the papers and start to actually form. It's got to be a conversation that's outside of a load of academics. It's got to be a sort of an urgency to action that comes out of that high impact paper, and I think it's got to be that sort of impact dissemination piece that we write in our grants. It's done so badly. So I think that for me is the thing that I'm definitely thinking a lot about at the moment.
Thank you. Yeah, really something for all the academics in the room to definitely think about.
Yeah, I really echo all the points that have been said. I guess, it's on all of us we all hold power and privilege in one way or another, and it's up to all of us to kind of constantly review this and keep this in mind. The other thing I would say, really, like, allyship is like a term that's used quite a lot in the equality and equity space, but allyship to me is a verb, it's not a noun, it's not a badge that we can wear. So we need to constantly think about how can we show up and show solidarity for marginalised communities, colleagues, researchers, whoever we come into contact with. And I guess I do quite a lot of organising outside of work around equality, and there's some principles that we use around honesty, hope and humility, and I think it applies also within this context. So honesty in the sense that with change, we also have to kind of reckon with harm that might have been caused in the past. We can't just say, suddenly we're going to change and move forward and things are going to be great. So it's important for lots of communities that there is that sort of like restorative approach taken around any harm that might have been caused by institutions. Humility in the sense that we don't have the answers. There's so many equalities challenges going on around us and in society today, but collectively we can work together to kind of unpack these and learn from one another. And hope, the last one is just having hope that social change can come about with, joined up, concerted action.
Thank you. Thanks, everyone. We have a couple of minutes left, so as a sort of ending final statement, you get one sentence, and really just one sentence, not multiple sentences that are one thought, to summarize. If you had to choose one thing you could change today or do today to think about population mental health and inequalities in this, what would that one thing be in one sentence? Who wants to go first?
Access to nature, I put it into legislation. I believe they have it in Germany that everybody's got a right to an outdoor space, and so all flats have balconies, if not access to a shared communal garden. We have a right to direct sunlight for a number of hours in the UK, which also is not adhered to. So I would put access to nature into legislation that everyone has a right to.
Okay, I'm going to nominate now, Jen.
Oh no. The first thing that popped to my mind, and this is not the most poetic or the most deep, it's a children's song, and it's "The more we work together, the happier we'll be." And I think that we do need to work together. I think that this is all of our responsibility, and we do just need to work together in order for us to really make a difference. Oh, that was way more than one sentence.
It's okay.
Okay,
Everybody's
sorry.
shifted.
Apologies.
Shiranjit?
I would say we'll see change when we see supported, empowered and confident communities standing alongside researchers, academics in working together towards making this world a better place.
Thank you. Jyoti?
So I think just to steal your point, I think I completely agree. We need much more involvement, and I talked about data, inclusive data that takes into account the ethics as well, and is put to work to really push forward change. But it can't happen in a vacuum. It's not going to just be academics. It's got to be everyone, including policymakers and the people on the ground who experience those adversities on a day-to-day basis.
Thank you.
I guess I'll just say momentum and consistency on all sort of like levels, addressing equalities. And I just really wanted to just point out, this week another young black man was killed by the police in London, and there's, where's the outrage on that? I feel like, some of our sort of messaging and progress around anti-racism in particular is something that I'm just worried is being stifled. So, momentum and consistency for me, and we'll realise change through that.
Thanks, everyone. On that note, you've been a wonderful audience and you've been a wonderful panel. Thank you, everyone, for coming. And if you are going to be at dinner, we'll see you at dinner.